Hello everyone, how are you? Hope all you're doing good and safe. Thank you for joining this webinar and thank you for Dr. Solara for organizing these sessions. I will start my presentation by introducing myself. I'm Fadia Kanaan. I'm the Regional Clinical Technical at Advanced Bionics. And I'll be talking today about neural response imaging, NRI, and programming. Our agenda will include an introduction. What is NRI, clinical applications, and programming? I will start with a small introduction about Advanced Bionics, or known as AB. AB, it was founded in 1993 by Alfred Mann with the mission to develop implantable patient care solutions that improves quality of life. In 2009, AB is acquired by Sonova, and we started to work with Phonak for future generation technologies that will benefit recipients and professionals. This is our headquarters at Steifa, Switzerland. We have our North American headquarters based in Valencia, California, and the European Research Center based in Hanover, Germany. And our MENA region offices, it's in Amman, Jordan. Now, we have a complete range of NAIDA hearing solution. And as I said before, we are working with Phonak. So as you can see in the picture, we are having the same genetic chips. So all technologies that we can find in Phonak, the hearing aid company, we can find it in our processors at AB. So it's the power of two working together as one. So as you can see, we have all solutions that will meet each recipient's needs. We have a cross solution, bilateral solution, bimodal solution, and acoustic ear hub. Now, AB's mission is first to dedicated to improve the lives of developing technologies and services that help our recipients achieve their full potential, commitment to putting patients first and providing the best possible hearing performance. The trust patients and professionals place in us inspires us to act with integrity and transparency, strive for excellence each and every day. Now, let's see what is an NRI. NRI is a neural response imaging, and it's incorporated in the Soundwave. This is our fitting software. The NRI, it can be used with the following implants from the C2 till the newest one we have, the Hires Ultra and the Hires Ultra 3D. Now, the NRI is the most commonly used objective measure in clinics. It's the measurement of the electrically evoked compound action potential, the ECAP. And now we will see more in detail about this. But as you can see, there is this beautiful graph consisting of an N1 and a P2, and you will see later what does these abbreviations mean. Now let's see a little bit what is a compound action potential is. An action potential is a small change in voltage resulting from the firing of neurons. The synchronous firing of neurons creates something which is called a compound action potential, the CAP. This is when we are in normal hearing, this is what happened. But what is an electrically evoked compound action potential? The ECAP is the response obtained when an electrical stimulus is used to record compound action potential. So this is very important to know that it's an electrical stimulus that we are giving. So as you can see here in the example, we have many of it. Here is the graph, as beautiful, an N1, P2, N1, P2, and here at the 150 CU, 200 microvolt, we have a beautiful N1 and P2 graph. So the ECAP consists of a negative peak, which is the N1, followed by a positive peak, which is the P2. The N1 latency is typically between 0.2 and 0.5 millisecond. The P2 is less robust, so the latency occurs before approximately 1 millisecond. The most important thing to know or to see is the amplitude between these two, because this is the one which is measured, and it's in microvolt, and it varies across individuals from 20 till 1,500 microvolt. Now I will talk a little bit about the ECAP stimulus parameters. We have three. I will be talking about these three: the stimulus waveform, the stimulus rate, and measurement parameters. Let's start with the first one, the stimulus waveform. The stimulus waveform is used to elicit a neural response with our system. So we use a biphasic pulse with monopolar coupling, a pulse width of 32 microseconds, which is by default in our system. But we just have to keep in mind that the pulse width must be long enough to produce a highly synchronous response, but at the same time, it must be shorter than the latency of the response, which is approximately before 1 millisecond. So as you can see here, the stimulus, this is the pulse width, 32 microsecond, 32 microsecond as well. And the response here, we have the N1 and we have the P2. So we have to take care that our pulse width should not be more than our latency response, which is less than 1 millisecond. Now, our second parameter, the stimulus rate. Let's examine now how the effects of the stimulus rates play on the neural response. ECAPs are measured when the neurons fire in synchrony. However, if we have a faster rate is used, what we see is that the neural begin to fire stochastically. So it will result in a less synchronous response and a disappearance of the ECAP. So as you can see here in this graph, when we are increasing our stimulus rate from 30 to 80 to 200 to 2000, we are seeing that our ECAP is disappearing, and this is what we don't want. Therefore, within our system, we are using a 30 Hertz as default for our stimulus rate, so we can have a maximum of neural synchrony. Thus, we are increasing the likelihood of obtaining a response. Now, our third parameter is the measurement parameters. The measurement level used for an NRI are in clinical units. It's as same as our Soundwave program. As you can see here, when we are stimulating on this electrode, by default, our system will be recording 2 apical electrodes, which means that we cannot stimulate and record at the same electrode due to the artifact issue. And we know the ECAP is in challenge with the artifact. So we don't want to increase the artifact. We want to decrease the artifact and optimize our stimulation and recording to obtain the ECAP. So that's why, as you can see, we have 2 ways. We have an ascending and descending stimulation level, and this means from high to low and low to high. And it's, as I said, by default, if I'm stimulating electrode 10, I'm recording on electrode 8 and apical basal, and as you can see, but we just need to keep in mind that we cannot stimulate and record at the same electrode. For the ascending and descending stimulation level, it's ascending from low to high, and we are using it when our patient is awake, and descending from high to low, we are using it in the OR because our patient is under sedation, so he's not going to be annoyed. For the ascending one, it's just to be more cautious approaches with our patient. Now I will move for this beautiful table. It's a small difference between NRI and ABR. As audiologists, we all do ABRs test in our clinics and the hospitals. But for the NRI, we have to do it when we have a cochlear implant patient. So this is a small difference between both. The stimulus type in the NRI is electrical and ABR is acoustic. The electrode is intracochlear. In the NRI, it's a skin surface with the ABR. Now the waveform in the NRI, as I said, we have the N1 followed by the P2 peak. In the ABR, we have all know that we are searching for the wave 5, but what I want you to know as well as the cross here is defining the wave 1 in the ABR is similar as the NRI we're getting in our system. The averaging is 32, and ABR is more than 1,000. In NRI, we don't need sedation, and ABRs we need. The benefits in NRI are verifying the neural function, and it will guide us for programming. In the ABR, we are estimating the hearing level. Now, what are the clinical use of NRI measurements? Why we are doing this test? The NRI, as I said, it can be done intraoperatively and postoperatively. It's used to determine if our auditory nerve is responsive. as you know, we are doing cochlear implants for deaf people. Mainly, they has been for a long time they are not hearing. So we just need to see if their auditory nerve is still responsive. It's important because it provides us reassurance to the family and the recipient, especially when we have children as a recipient. We know he can just fall down, just can hit his head, any accident, any trauma. So this is an assurance to us as clinicians, as audiologists, and for the family and the recipient that everything inside is still working, we're fine. And it's important as well to establish a baseline and assist with programming. But we have to keep in mind that the ECAP results, it's not a predictor of patient performance. So it's not related. If I have ECAP, so the patient has to perform well. So it doesn't, it's not related. Now I have factors that influence my NRI response. Yes, I have, and it highly influences it. It's influenced by neural survival, synchronous neural activity, electrode placement relative to the nerve, electrode impedance, tissue, and status of the cochlea. Now, I know that some of us have this question with, which is, can the NRI results change over time? And the answer is yes, it is possible. Physiological changes, particularly during the first 6 months post-implantation, because as I said, we are activating our nerve, we are stimulating it. So it's normal, it's logic that we will have these changes and the results. Tissue or status change in the cochlea can occur, and noise biological level changes. And of course, with this issue, we still have many research, many studies that are still proceeding just to see and to be sure what as well can change or can be affected to change our NRI result. Now let's move to see how we perform our NRI in the Soundwave. First, we have to connect our hardware. We connect the CPI3, we connect the processor, and we can check that everything is detected. As you can see here, our implant is ready. So everything is good with the connection. So we can move forward. We have something which is called NRI templates in our software. So all we have to do is just to click on template, and we can see that we have use NT1, use NT2, NT3. These three templates, they are a preset templates done by AB. They are by default in our system. Or we can customize our own template by pressing new. So this is important because it helps clinicians to save time, and it's easy and flexible. So as I said, AB, it will provide 3 preset NRI templates. The N1, which is the OR, it's descending. As I said, it's from high to low. Our patient is under sedation. So when we are in the theater after the operation, we want to perform the test, we just can choose OR and start the test. Otherwise, we have adult and pediatrics. So these templates, they are already prepared by AB. So all we have to do is just to choose our template, the one which is good for our patients, the one that suits him, and just click start. And this is what we will have on our screen. This is the software page for the NRI measurement. These are our 16 electrodes. And as you can see here, we have 3, 7, 11, and 15. These are the 4 electrodes that are already chosen by the template. They are by default chosen. As I said, we can change it manually by creating our own template. So, and as you can see here, 3 is checked, 7 is checked. It means that on electrode 3, I already had my NRI result, as well on 7. 11, it's still under measurement. So as you can see here, we have a response at 150 CU, a response at 200 CU, and it's still measuring at 250 CU. So it's many response that we are having at different CUs, just by the end to have the T and RI for each electrode. So as you can see here, we have a growth function here. It's microvolt, and it has to be a linear growth. Okay, I will explain more about this. I want to talk a little bit about the TNRI versus the first NRI, because there's always a confusion between these two. Our first NRI, it refers to the lowest CU level that would elicit our first visually detected neural response. It occurs between 20 microvolt and 50 microvolt usually. So let's see it here in this graph. So our first NRI is here.